So let's think about the daily highlights for Saturday, the 3rd of June, EULAR Milan 2023. Hello and welcome to the final day. My name is Peter Nash, Professor at the School of Medicine, Griffith University, beautiful downtown Brisbane, Director of the Rheumatology Research Unit on Sunshine Coast. As the Congress comes to an end, let's highlight what I feel the sessions of interest from the CSF perspective, including a wealth of important abstracts on this final day. There's some nice posters on emerging therapies, as well as cardiovascular implications of JAK inhibitors that are on today to have a look at. There are two posters that focus on safety in JAKs. That includes the latest by Mayer book on the long-term safety profile of JAK1 preferred filgotinib in patients with rheumatoid arthritis, and Gottenberg and partners review the data from the relation study on tofacitinib and CV events. First of all, Paul Emmer and his colleagues report the latest efficacy and safety, and this got into the New England Journal of Medicine, on peresolimab in rheumatoid arthritis. Now, peresolimab is a humanized monoclonal that stimulates PD-1, and it's hypothesized that by binding to PD-1, you'll stimulate immune inhibitory pathways to restore immune homeostasis. So they've done a study looking at the efficacy and safety. The trial met its primary endpoint, greater improvement from baseline at week 12 in the DAS28 CRP versus placebo at both tested doses. There was significant improvement in CDAI as well, and there was dose relative to placebo of the two doses. ACR20 was also significant for the 700 milligram dose. And the safety and tolerability profile supported going further from phase 2 into phase 3. So an interesting approach, trying to use PD-1 inhibition as a way of stimulating immune pathways. In fact, it's not PD-1 inhibition, it's PD-1 stimulation, the natural inhibitor of immune pathways. So a very interesting approach. You'll recall that abatacept, the CD20 inhibitor, also tries to do the similar lines of therapy. The next poster looks at long-term clinical profile of filgotinib in patients with RA and looked at cardiovascular risk factors. This is a post-hoc subgroup analysis. This is a JAK1 preferred inhibitor, and the key results really that the adverse events were generally high in patients over 65, as we know, and the cardiovascular risk in patients over 65 was the issue, and not under 65 without cardiovascular risks. So I might do that one again, if you don't mind. So let's just read that through. So generally high in patients age 65 versus yes, and high in patients with or without, or with cardiovascular risk, and patients without cardiovascular risk. Okay. So the next poster was the long-term clinical profile of JAK1 preferred inhibitor filgotinib in patients with RA, looking at cardiovascular risk factors, and this was post-hoc subgroup analysis. They looked at pooled analyses on the long-term safety of an efficacy. They looked at the two doses, 200 and 100 milligrams, and they looked at patients over 65 and under 65, and looked at these subgroups of patients on the two different doses. And the incident rates were generally higher, as you'd expect, in patients over 65 compared to less than 65, and higher in patients over 65 or with cardiovascular risk factors compared to patients under 65 without cardiovascular risk. So that in the patients over 65, lower incidences of malignancies, in particular non-melanoma skin cancer, zoster, leading to death, were observed with 100 versus 200. So there seemed to be a dose effect there. So age was highlighted as the most important risk factor for filgotinib, particularly at the 200 milligram dose. So a poster worth having a close look at, as it gives us a clue to which patients to be careful with and which patients are most appropriate for use of that JAK inhibitor. The relation study was a nationwide cohort study reported by Gottenberg et al., and it looked at acute cardiovascular events in RA patients treated with tofacitinib and compared that to the TNF inhibitors in immune-mediated inflammatory diseases, particularly RA. And given oral surveillance, this is an important question to try and get evidence from real-world data, what's going on, TOFA versus TNF, because you'll recall the Cora Vita study and the STAR study didn't show the MACE issues that were shown in oral surveillance, and they compared to the TNFs, and they had very large numbers that they followed, over 100,000 patients in one of those studies. So the key results from the relation study, the risk of MACE was similar between the two, whether it was ischemic heart disease. There was too low numbers of peripheral artery disease to perform any analysis. But in this real-world data, and you'll have to look at the poster for the numbers and the baseline demographics, etc., tofacitinib was not associated with an increased risk of MACE when compared to TNF in patients with RA. So if we look at the important paper looking at the EULAR recommendations update will be presented on this morning by Laura Gossick, an interesting presentation, and it really will focus on a domain approach. It'll focus on 17s, 23s, the 17A and F, and the JAKs, and where to position them in the treatment algorithm, which patients are most likely to benefit from which particular therapy, whether it's axial involvement, uveitis, IBD, peripheral joints, skin, etc. So you'll find this session helpful, and I think it'll have an impact for regulatory authorities and reimbursers around the world. And it'd be important to stay up to date with those recommendations. Phil Meese will present the phase 2 deucravacitinib data. This is a TYK2 inhibitor, already licensed in a number of countries for the treatment of psoriasis, and he'll look at pain in a post-hoc analysis of patients with active PSA. And there's some guselkumab data on long-term efficacy and safety, as well as for upadacitinib by Dennis McGonigal and Ian McGuinness. So a number of important abstracts, the phase 2 deucravacitinib TYK2 study in active PSA, and this was looking at improvements in pain, and while you control inflammation, you will certainly improve pain as well, as Phil has documented. Guselkumab, long-term response in a post-hoc analysis through 2 years. They had very high retention rates, and they really showed very nicely that skin and enthesial responses at the start predicted long-term response, including disease remission, and showed nice persistence of efficacy over time. The safety of upadacitinib in psoriatic arthritis, these are the 3-year results from the phase 3 Select PSA-1 study. And bottom line key results, the imaging results were similar between upadacitinib 30, a dose that isn't recommended or available in our country, at least 15 milligrams is our dose, compared to adalimumab, if you like, the gold standard, numerically higher than the upadacitinib 15 dose, but overall the safety profile remained unchanged out to 3 years. So the efficacy in non-BDMARD IR patients was maintained out to 3 years, and there seemed to be a dose response compared to adalimumab. If you look at AxSpA, there's one very interesting post from the final day by Oliver Fakir, and discusses the relationship between NSAIDs and MACE in AxSpA, because one of the common questions is, should NSAIDs be used continuously or on demand in radiographic AxSpA? And this looks at the impact of NSAIDs on the 8-year incidence of major cardiovascular events in patients with radiographic AxSpA. And hasn't been studied very well. The question really is continuous versus on demand. And during the follow-up over 8 years in quite a large number of patients, they identified a number of MACEs, a number of deaths, and they quote the cumulative incidence in the 1.8, just under 1, and just 0.85% respectively, and they analysed them in a univariate analysis for age, sex, diabetes, lipids, and hypertension. And in fact, the NSAIDs and the TNFs were associated with a lower risk of MACE events, which was not the case for other conventional synthetic DMARDs. So they suggest the hypothesis that there needs to be tested, that there may even be a protective role of NSAIDs and anti-TNF drugs on cardiovascular risk. And the question is controlling the inflammation more important than any risk that an NSAID might add to the cardiovascular events in these patients? There's lots of standalone abstracts of importance. There's some in RA, PSA, and ACSPOND, and these recommended abstracts and all the other sessions can be found in the CSF preview brochures that you can download. This paper by Aru looked at filgotinib and its efficacy and safety in people who have failed multiple BDMARDs and 2 other JAK inhibitors. And the bottom line was that filgotinib was still able to show clinical improvement with a low adverse event rate. And the intriguing thing about filgotinib, there seems to be less of a VTE signal and even less of a zoster signal from the clinical trial point of view. So real-world data from long-term follow-ups in registries, etc., are keenly weighted. Baricitinib monotherapy for the treatment of RA. Here's the 5 real-world data sources presented by Chris Edwards, and they looked at the use of baricitinib as monotherapy. Half the patients in those studies, RAB Real, Orbit RA, and SCQM RA, were taking, and the British Society of Rheumatology Biologics Registry for RA and the EULAR baricitinib cohort, about half the patients from monotherapy. I'm surprised it's not more like 70-75%. They had quite nice numbers that reached low disease activity or remission up to a year of monotherapy across the different groups. And they don't comment particularly about safety in this analysis, which is the key for this JAK2 inhibitor in particular, but the efficacy data is nicely presented. There's a nice paper that looked at prevention of bone destruction using markers of bone resorption as well as indicators of bone formation with these 2 JAK inhibitors, baricitinib and upadacitinib, which both have been shown to inhibit radiographic progression. And in this paper, treatment with either JAK inhibitor seemed to turn off increased resorption and showed some evidence of an bone anabolism in patients with RA, and they showed the biomarkers over 12 months of therapy. An interesting paper to study the possibility of not only stopping erosions, perhaps healing is something that needs to be examined further. The next paper looked at bimekizumab, the IL-17A and F inhibitor in psoriatic arthritis, and looked at the efficacy over a number of the composite measures of disease activity, comprising joint and skin domains against placebo. And they looked at things like very low disease activity, the measure used in some of the head-to-head IL-17 versus TNF study, particularly Spirit head-to-head, ACR 50 plus PASI 100, and they looked at DAPSA and PASDAS, the disease activity measure, at a year, and surprise, surprise, bimekizumab demonstrated meaningful improvements in those composite measures, an effective agent. From the COSMOS study, which is the TNF-IR gaselkamab P19 IL-23 inhibitor study, they looked at early response as a predictor of long-term improvements in HAC. A lot of these patients had long-standing disease, so there will be an irreversible element to their HAC. But if you're an early responder, according to this study, then you have, over time, much improved health-related quality of life improvements. Another predictor of long-term quality of life PSA study with gaselkamab. This is the phase 3 study. And again, if you respond by week 8, you've got a great chance of having improved health-related quality of life through 1 to 2 years. Retention rates were very high with this agent, and improvement over time is what is often seen. Long-term safety of ixekizumab IL-17A inhibitor in patients across the PSO, PSA, and AxSpA spectrum. Another post-hoc analysis looking in particular at major adverse cardiovascular events. There's no signal that the 17 should cause any MACE events. And in this study, the MACE event was low, stable, and not particularly aggravated by the treatment of these patients with IL-17A inhibition with ixekizumab. As you would expect, treating inflammation is the most important thing to do. This is the efficacy and safety of tofacitinib in AS, radiographic AxSpA, using baseline CRP. In our country, you have to have an elevated CRP to get reimbursed, or the regulatory authorities allow you to use IL-17 inhibition in radiographic AxSpA. And most of the other agents, particularly TNFs, have shown that if the CRP is not elevated, then it's difficult to show superiority over placebo. But with ixekizumab, that wasn't the case. And in this study, the tofacitinib was more efficacious than placebo, regardless of the baseline CRP. That's an important study and something that we can take to our regulators and say that those patients with who do not have elevated CRP are still going to respond to therapy, and they should reconsider their regulations using ixekizumab and this tofacitinib study in particular. Looking at the comparison between secukinumab and IXI, they were both valid options for PSA and AxSpA with no significant differences between the two drugs, as you'd expect. They both work well, and there's a number of anecdotal case reports of a patient failing one, responding to the other, even though you think there's full IL-17 inhibition, and it works both ways. So another busy and insightful day at EULAR 2023 to look forward to. A great way to end the Congress with lots of important posters, recommendations, novel therapies, treatment updates. I hope you've enjoyed this roundup of day 4 and the highlights we've suggested at this year's meeting. You can download the EULAR 2023 highlight brochure from cytokinesignaling.com. You can see all the abstracts, you'll have slides, etc. So thank you very much for joining me today. I look forward to more informative and interesting podcasts coming to the CSF forum soon, and thank you for your time.